Chest tube thoracostomy is a procedure where a hollow plastic tube is placed between the ribs and the chest to drain fluid, blood, or air from the space around the lungs. The tube is hooked to a suction machine to help with the drainage. Here are the following materials needed: sterile surgical gloves, chest tube at least 28 French. I'm using a nasogastric tube as an alternative. Towel clips, I'm using paper clips instead. Syringe with local anesthetic, plaster, vaselinized gauze and sterile sponges, povidone iodine antiseptic, cut down set, and silk zero suture. Place patient in a semi-upright position with the arm placed above the head to ensure chest exposure. With the sternal angle as the landmark, palpate for the second rib and move downward to locate the fourth or fifth intercostal space in the anterior axillary line. Prep the skin with povidone iodine using forceps and cotton balls in a wider area in case there is a need to go further in the insertion. This should be done in an outward concentric motion and repeat this 3 times to ensure sterility. Drape the area with 4 towels and not with a single fenestrated sheet. First towel is on the surgeon's side, cephalad, cauded, and the side opposite that of the surgeon. Infiltrate the skin with a local anesthetic and block the intercostal nerve branches at the 4th or 5th intercostal space of the anterior axillary line. Make sure to infiltrate the pleura as well. Make a 2.5 to 3 cm incision into the subcutaneous tissue. Incision site should be close to the upper border of the rib to minimize injury to the nerve and blood vessels on the lower border of each rib. Insert a curved galley clamp or Mayo scissors to separate or cut the tissues in creating a tunnel or tract in the direction of tube insertion. Direct the tract posteriorly, cephalad, and medially so the tube lies posteriorly in the paravertebral gutter. Continue developing the tract into the pleura. Remove the clamp and explore the tract with a gloved finger from time to time to ensure that the tract is in the right direction. The entry into the pleural space through the parietal pleura gives out a sudden release of resistance. After the pleural cavity has been entered, explore for adherent lung with your gloved finger that may impede passage of tube into the pleural space. Further enlarge and open the pleura with a large galley clamp. Grasp the tip of the tube with a curved galley clamp wherein the long axis of the tube is parallel to the long axis of the clamp. Make sure to clamp the distal end of the tube if hemothorax is suspected. Insert the tube to the chest with a large scaly clamp as a guide. Aim the tube apically if air is suspected and basally for fluid. Remove the clamp when the tube has reached the desired position in the chest. Make sure to turn the tube to assess no kinking. Palpate superiorly and inferiorly to ensure that the tube has entered the chest. Suture tube to the skin with silk zero. Make sure to secure the knot tightly to ensure stability of the tube and avoid air leaks around the tube. Cut the needle to avoid accidental puncture. The free ends of the suture are wrapped around the tube. Make at least 4 loops to secure it in place. Push suture down and secure with a knot. Before unclamping the distal end of the tube, connect the tube to the underwater seal chest drainage system. Dress the tube with a vaselinized gauze around it and push up against the chest to ensure no air leak. Cover tube site with a 4x4 sterile gauze with a slit and secure with a plaster. Obtain a post-tube insertion chest X-ray to check the position of the tube. The radio-opaque stripe is visible, with the interruption indicating the position of the proximal hole. Ensure that the hole is within the pleural space.